Welcome to Moving Medicine, a podcast by the American Medical Association. Today's episode will pick up on the conversation with AMA immediate past president Dr. Jesse Ehrenfeld and experts talking about new telehealth licensing models for physicians. Panelists include Clark Barrineau, Assistant Vice President of Government Affairs at the Medical Society of Virginia; Marschall Smith, Executive Director at the Interstate Medical Licensure Compact; and Dr. Sarvam TerKonda, Immediate Past Chair of the Federation of State Medical Boards; Jared Augenstein, Managing Director at Manatt Health Strategies; and Kimberly Horvath, a Senior Attorney at the AMA. If you missed part one of this series, I encourage you to go back and give it a listen. We're jumping right back into the conversation with a question for Marschall Smith about the Interstate Medical Licensure Compact. Here's Dr. Ehrenfeld.
Marschall, can you tell us about the current state of the IMLC? How's it being utilized? What kind of data do you have around the number of physicians that are participating? And what's the pathway to get 50 state participation?
So the compact, thank you. Let me start out by saying thank you. I appreciate the invitation to participate in this panel and discussion. So we have over 16,000 physicians that have utilized the compact and the compact process. Those 16,000 physicians have completed and received 48,000 letters of qualification. And as a result of those letters of qualification, over 75,000 licenses have been issued to physicians to practice medicine in the United States. We just completed a study of looking at the new licenses issued in the United States in the calendar year 2022. And what we found was that 17% of all new licenses issued to physicians in 2022 came through the compact process. That includes states that are part of the compact and not part of the compact. 17%, or almost a fifth of all the licenses issued in the United States in 2022 to physicians, came through the compact process. And looking just at our member board, so the states that are participating in the compact, there are 39 states, the Territory of Guam and the District of Columbia. 31% of those, on average, 31% of all the new licenses issued in those states came from the compact. So with regards to that, the compact, and I would like to state, on the record and publicly that the compact really is agnostic with regards to all of these different approaches to getting physicians so that they can practice in their state. It is really, I think there's a misnomer that there's, in a sense, a competition between should we do this or should we do this. And really, I think the smartest approach that I've seen, and it certainly is one that the compact endorses, is why shouldn't states create opportunities, or in a sense, a tool belt for the physician to make the decision on how they can best provide the care to their patient, whether that's obtaining a full and unrestricted license through the compact process, the traditional process, doing reciprocity, and all of those sorts of things. So not wanting to get into that debate, but I think that's certainly a part of that. And then before I get to how we're going to get to all 50 states, which is what we will do, I've made that my enduring vow, and it'll be marked on my tombstone. We keep hearing there are two main pain points for physicians with regards to the compact process and obtaining state-based licensure and that. The first is regarding the cost or the fees that are associated with that. And the compact really has no influence or ability to influence our member boards and the fees that they charge. However, I would note that most states look at the fees that they charge on an annual basis. And we've had 5 states that have reduced the cost of all licenses or physician licenses for all physicians, not just compact licenses. And I think the compacts and the input that we have had in providing those additional licenses for those states have had an impact on that. So I think that was one of the things that will continue to happen. The compact itself, we look at our fees Every year, we have a model that we look at our revenues. We're trying to anticipate that going out into the future and making sure that what we charge is appropriate. I am aware that there is a study being done and hopefully will be published in October so we can actually talk about it. But this study, it's a university has been studying the compact since 2017. And what they found is that states that have introduced the compact have reduced the overall, not just the licensing fee aspect and the preparations aspect, but all aspects of a physician preparing to be able to have a practice in multiple states. Meaning that sometimes there is a variable amount of knowing when you're going to get that license in that state and being able to establish your practice and open an office and hire staff and all that stuff. The compact provides a stability to that. There is a very strong evidence with regards to how quickly physicians can get licensed. And that average for us is about 7 to 10 days. So it is a known factor, and all that will be coming up. The second pain point is with regards to keeping track of all these darn licenses that I've now got. And the compact is making a major investment. We just have engaged a vendor, Mockingbird, to create what we're calling an enhanced physician portal. That enhanced physician portal, the goal behind it, and we're intending for it to be rolled out about a year from now, will be in a sense an electronic physician wallet. The physician in one place will be able to track all of their licenses that they currently have, that they've ever held, and those licenses that they're currently using will be able to record and keep track of all the continuing education requirements, all the requirements for all of the different states, and it'll be in one place and it'll be electronic and be available for those physicians. So we're doing that. Now to the tricky question of getting all 50 states. Part of what we're finding, especially now that we're down to the last 11 states, is really there isn't much, and this is an overly broad statement, but there really is not much opposition to the compact and to joining the state. It's really more of an apathy. Someone has to, the compact, the way that it's designed, we can't advocate for the introduction of the bill. We can provide information and education and support the bill once it's introduced, but it's finding that advocate, especially in those larger states like California and Florida, and getting that advocacy moving forward. Once it starts, it's generally found there really is no downside to patients by having the compact in a state, and that really the fears that have prevented some states from joining the compact, that it's going to take away physician jobs, it's going to have a negative impact on the hospitals and their ability to have local talent that is not really going to reach out to rural and underserved areas. All of those really are being found to be false. We've been in business and operating for 6 years, and the data is supporting those claims that those concerns and fears are not based in fact. And so one of the things that we're doing is we're working on our advocacy. We're doing these studies, looking at the data, getting hard information so legislators can make their decision about that. We're surveying physicians to find out if the compact is meeting their needs and if we're doing things appropriately. And I think the answer starts to become, it really does make sense for a state to join the compact. It's one more tool for them to use, or for physicians to be able to use, to be able to practice in their state and address those issues. We're also, one of the things that, I've seen an advanced copy of this study, and I'll close with this comment, but one of the things that study has found is that, and they actually have the data to support it, is that the single most important activity a state can take to increase the number of licensed physicians in their state is to join the compact. It's twice as effective as all of the other methodologies, where you're forgiving student debt, where you're creating reciprocity, where you're creating special licenses or special processes. joining the compact is 2 times more effective than all of those other things. And so I don't think it makes sense for a state not to join the compact and do these other things too if they believe that's important, and we support that activity. So with that, I will be quiet and thank you again for this opportunity to participate.
Medicine doesn't stand still, and neither do we. AMA members don't just keep up with medicine, they shape its future. Help move medicine, join the movement. Visit ama-assn.org/movingmedicine.
Fantastic. Marschall, thank you so much. And let me turn to Clark. So Clark, the National Capital Region has been at the vanguard of thinking around licensure policy. Can you kind of walk us through how Virginia developed reciprocity to licensure with DC and Maryland, and why is that important to physicians?
Yeah, absolutely. So here in Virginia, we are obviously blessed with close proximity to several advanced states in the world of healthcare. So several years ago in 2018, Senator Barbara Favola of Northern Virginia obviously being usually at the forefront of these conversations, having a lot of people go in and out of both DC and Maryland due to employment with the federal government, asked the Board of Medicine here in the Commonwealth to look at reciprocity. And that was just what we call a Section 1 bill, but it just said, Board of Medicine, go figure this out, was essentially what the bill said. You don't need to go to law school to write that one. And of course, when it comes to reciprocity, it takes 2 to tango. So you can't just establish reciprocity. My wife had to say yes to marrying me. A state has to say yes to doing licensure reciprocity. And so they reached out to all of the available states that applied. So North Carolina, Tennessee, DC, and Maryland. In Tennessee and North Carolina said, no, thank you. DC and Maryland said, well, let's wait and see. So the conversation kept going and going and going. And then, as many things in the world of telehealth post-COVID, the floodgates really opened up. DC and Maryland's either through a leadership change or just advocacy therein said, hey, let's do it. And then consequently, over the past year, really 2 years ago, I suppose, they hashed out all the legal arrangements. And then that went live in the winter, the late winter of 2023. So currently, if you are a licensed physician in Virginia, Maryland, or DC, we now have licensure reciprocity, meaning with hopefully just a few clicks of the button at your associated Board of Medicine state site, you can get a license in as little as 48 hours. So we're still hoping for Tennessee and North Carolina to come on board. I asked our chairman of our Board of Medicine, have you heard from them in a while? And then he tells me some unkind words, but we're still trying to do that because we still have individuals in those regions where I think it would make a lot of sense to have that arrangement. But it's been a boon to members of the Commonwealth and physicians therein. And as a former resident of Alexandria, Virginia, who lived in DC and dated a girl in Maryland, I can tell you that reciprocity is much needed.
Very, very helpful. Let me throw out 2 questions for anybody on the panel, and folks, feel free to just jump in. Biggest opportunity for the industry and states when it comes to developing telehealth licensure regulations, and the biggest risks. What do people think?
Well, Jesse, I can just start off just in a general way from a board perspective. Well, we're going to expand access to healthcare. I mean, that's one of the biggest reasons to bring telehealth to the forefront. It reduces those geographic barriers, allows for improved and specialized care, hopefully, and access to that, and improves continuity of care. I don't know if we can actually say we have reduced wait times, because we still don't know if access has really improved incredibly through telehealth. Hopefully we can improve on chronic disease management and mental health services, which has been at the forefront of telehealth from the beginning. You can see that mental health services have increased dramatically over the past few years. So I'll let others speak to some of the opportunities for improving telehealth licensure portability.
Jump in.
Okay. So I would say, I think one of the biggest potential issues or hurdles with regards to telemedicine and its adaptation and providing medical services is that there's a danger or a fear I think there's a danger with regards to the idea that it's different or it's a special kind of medicine. And in reality, it is not. It's a modality by which physicians can provide treatment to patients. And I think the more we bring it back into that concept that you have to have a license to practice medicine, and as a professional, the physician is responsible for figuring out the best way to treat that patient. It may be telemedicine, it may be inpatient, but getting away from treating telemedicine as something special or something unique, while it is, and I understand where we've gotten to, but I think if we continue to take that too far, I think I would have a fear that we start creating special licenses for it, and then it becomes a different type of medicine.
And then I would just add, as a lobbyist, I think about threats all the time. It's a very healthy way to live. I would just say the threat is the opportunity for money when it comes to telehealth and licensure. Here in Virginia, we're seeing a lot of corporate interests start to staff up and lobby up when it comes to the world of telehealth. And there is a scenario that I don't think is too crazy to think that those interests want to basically churn and burn telehealth services without state licensure. So they want to pick whatever state is the cheapest state to do business in, warehouse a bunch of kiosks with a fast internet connection, hire some mid-level providers, and then churn and burn telehealth visits. You only need to Google the company Cerebral, which made the New York Times about a year ago, I think, which is in the telepsych space. But that is the worst case scenario of what we have, which is why, at least here in Virginia, the state level boards and that protection, that patient protection that you talked about is kind of our line in the sand on any telehealth piece of legislation, and probably going forward always will be.
Very helpful. So, Sarvam, Clark, what are you hearing from physicians, people who, practice telehealth in addition to an in-person practice, telehealth only people? What are your experiences with the licensure flexibilities that we had during the public health emergency that people really want to see carried forward?
So, feedback from some of those physicians early on was a challenge. There were those that adopted telehealth fairly readily and quickly, and then those who were a little bit more traditional wanted to see their patients, so they had a little slow adoption. But those who embraced telehealth actually have a very high both patient and provider satisfaction, physician satisfaction, upwards over 90%. Those, as Clark's, or I think Marschall, the standard of care is the standard of care, whether not dependent on the modality. And so those who embraced that thought process as they moved forward, ensuring that when the patient was seen, that the standard of care was met for that patient, did very, very well with embracing telehealth. I think some of the flexibilities that patient or the providers miss from the PHE or the emergency is, the waiver of the state license requirements. We didn't have to worry about having licenses and having state boards maybe look at your ability to practice in that area. We also didn't have the issues surrounding reimbursement. We saw Medicare, Medicaid, and relax on their requirements for where telehealth could be practiced, and also endorse the payment methods for that. So I think that's where we see the flexibilities. If we can't improve on payment models for telehealth, I don't think we'll grow it any further.
Thanks, Clark.
And then here in the Commonwealth, we're really having conversations about how all in to go with telehealth is what I'm hearing. Obviously, we had the expansion, COVID and post-COVID, and then the question is, should I keep doing this much telehealth versus this much in person? Should I go all in? And I think what you're seeing is an ongoing conversation, and I know the leadership at the AMA is talking about this, but what do patients want out of their providers? What do they expect? I have two small children, and I'll tell you, pretty much every pediatrician I've ever come into contact with just gives out their cell phone number now and says, text me when you need me, when things come up. And that's almost going to be the expectation, I think. But that is a immense burden on the physicians and provider community to basically be available at all hours of the day. So if that's something that we're gearing towards and patients have come to expect, is that something that's sustainable? And then what protections, both financially, personally, can we build in to make that happen?
Thanks. So let me ask one more question for Marschall. Any future where there emerges a national compact structure that offers reciprocity as some newer licensed healthcare professional compacts offer?
That I would say I think that is probably more of a good think tank topic. Yes, I think looking at how do we, because the compact itself and the way that it's established has a high bar, bright light standard that if a physician meets this, they can participate, and if they don't, they can't. And I think it does miss out on those physicians who are just graduating and who have an opportunity. And I think that really, to me, is kind of the next opportunity, the next kind of compact. How do we compact 2.0 or something like that of where, now that we know this process works and it's there, how do we start expanding it out and make that available to more? Did I get to the question?
Yeah, no, that's great. Thanks for that, Marschall. So let me throw one out to everybody. Any interest in solving this on a national or regional approach, or is it just going to be state by state? Is there any reason there can't be a United States medical license?
Congress.
Say more.
Oh, I think the legislative possibilities of such a thing would be very, very difficult, but that's all.
And I think also, for all of its controversy, the Dobbs decision really did reinforce the idea that the practice of medicine is a state-based activity. And so now we've got a Supreme Court decision that supports that concept. And I think it would be difficult to overcome that sort of a legal challenge to create a national license. But again, and those are my opinions, not the opinions of the compact. But I think that's where coming up with a national license, I think, is a dead topic in today's environment.
Jesse, if I may add that,
yeah.
Building on Marshall's thought processes, as these licenses are state-based, you have to realize the Medical Practice Acts are state-based, and to try to align 50 states and their Medical Practice Acts would be exceptionally difficult. So I think that's one of the biggest hurdles in all.
Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine.
Let me stick with Marschall. So current certification by ABMS or AOA BOS board is required for participation in the compact. Because of some of the changes happening, requirements for yearly fees, MOC, many excellent physicians are letting their board certifications lapse. Are they still allowed to participate in the compact based on their initial certification?
Yeah, the board certification requirement is for the initial letter of qualification. And once the physician has their initial letter of qualification, they can come back and get more. The board certification requirement drops off. And that was in recognition of maintenance of certification and all of those sorts of issues and concerns that were raised. And so it's required as an initial, but after that, it's not required for the physician. So they can get their letter of qualification and drop their certification the next day, and they can continue to use the compact.
Very helpful. This next one I think is for probably Sarvam. So are physicians allowed to have a telehealth visit with an out-of-state new patient?
So, traditionally we say that telehealth should be for established patients, and that's where we believe is best approached. For a new patient, that patient needs to be seen by a physician that has a license in that state. If they're going to move forward with a new telehealth, you can see a new patient, but you have to meet the standard of care. If you need to have a physical examination to make a diagnosis, obviously telehealth prevents that. So you haven't met the standard of care for that patient. So remember, no matter if it's a new patient or established patient, standard care is the standard of care, and that must be met in evaluating those patients.
Very helpful. Kim, do you want to jump in on that one?
Yeah, I think the only thing I would add, I think Dr. TerKonda answered it perfectly. I think the one thing I would add is just that exception for consultations, right? Where if a physician has a established relationship with the patient is consulting, right, with another physician who might be out of state. That would be an area where they wouldn't necessarily need a license in that state, but that's a very kind of narrow consultation exception.
Yeah, and building on that, Kim, is, those exceptions for licensure, physician-to-physician consultations, prospective patient screening for complex referrals to centers of excellence. Episodic and follow-up care for established patients is the norm. And any type of follow-up travel, surgical or medical, and clinical trials. We think in those situations, that's an exception for licensure, and you don't necessarily have to have a license in that state where the patient's located.
Got it. Very helpful. So there's a question regarding shield laws and state licensure compacts and how they interact. Anybody want to tackle that one?
I will boldly go where most fear to tread. This is one of the most common concerns being raised, and we've had conversations and talked to, provided testimony to Rick Masters and I have provided testimony to state legislators about the shield laws, but also on the other side, there are concerns about those shield laws being overreaching and allowing physicians to go where to use that protection to provide services that are not in accordance with the Practice Act of the state. The compact has been very, very consistent and insistent on the idea that we are founded. Section 1 of the compact statute is each state has the complete and full right to regulate practice of medicine in their state, and they regulate that practice through the issuance of a license. That authority and that right of that state ends at their state border. And we continue to believe that is true. We believe that that's the best sort of federalism. We believe that's the intention of state-based healthcare regulation. And we continue to support that, and we continue to strongly say the compact supports shield laws. Being a member state of the compact provides additional statutory authority to protect those shield laws because of how the compact language is established and works. It also works for those states that have chosen to restrict the healthcare options for physicians to provide to women. And we are not wading into the politics of it. We're not wading into the right or wrongness of any of those decisions, but we are wading into the fact that it is each state's right to do that, and the compact supports that and supports those laws and supports shield laws, and it also supports those states that choose to have those restrictions in place.
Marschall, how has the Interstate Medical Licensure Compact helped physicians?
I think the biggest thing that we have done is made it easier for the physicians to practice and to expand their practice, and ability to control those costs. We know that on average it costs $385 to apply for a single state license using the traditional method. $700 is what the compact charges, and so if a physician applying to 2 or more states, it's more economical to use us. It's one place, it's one stop, it's one website. It's something we strive for. So I think it's something I'm very proud of, and my staff and the board staff. We have allowed boards to focus on. We handle the squeaky clean applications. The board staff gets to focus on those that require their expertise and knowledge to make sure that the license being issued is to a physician who is safe.
Thanks for that. Are there any states that require telehealth providers be physically in the same state as the patient at the time of the service, assuming that provider is licensed in the state where the patient resides at the time of the visit? Thought maybe New Mexico had such a restriction. The follow-up question is, what happens if the physician is abroad?
So, Jesse, there are some international laws that would prevent you providing some telehealth services if the physician is abroad. I think they have to look into those international regulations there. On the other hand, providing telehealth to international patients has also presents some issues. And one that I repeatedly hear is about China. If you're providing telehealth service to a patient in China, even if it's a U.S. citizen, that medical record has to exist in China and not in the United States. So I think going internationally, you have to be very, very careful, make sure you meet all the regulatory issues that may arise there. I think if you're practicing in a state, you have a state license in that state, and you're providing telehealth services. I don't think there's any state board that would say you couldn't do that. And I'm not familiar with what's happening in New Mexico, but I'd be interested to know.
Maybe Jared wants to weigh in.
Yeah, not on New Mexico specifically, but just to add one more layer to this, some states, this is not related to the ability to practice in the state, but from a payment perspective, some payers, commercial payers or Medicaid programs in particular, will often require either a physical address in order to enroll in the Medicaid program or with a commercial payer. And so it could also be that what is being seen is more of a payment level issue than the actual ability to provide the service.
Let me ask one last question, and then I'm just going to make a closing comment or two. And the question is, should pathologists who read glass slides from patients out of state have a medical license in the state in which the patient resides? And I imagine you could extend that maybe to a radiologist who's reading a film from a patient in a different state.
So that's an interesting question here, Jesse. And I think if you're a practicing physician, you need to have a license where the patient's physically located. To have carve-outs for specialties, I think it makes it much more difficult.
In Virginia, the answer is yes.
Sounds like there's consensus for yes. Well, awesome. Really appreciate everybody on the panel for walking us through some solutions. We've heard a lot today from our experts, and through the questions, learned a ton about how we collectively can support telehealth, not just for physicians who provide the virtual care, but at the end of the day, it's all about our patients who are relying on this modality. Bye-bye.
Thank you.
This has been Moving Medicine, a podcast by the American Medical Association. Subscribe today to never miss an episode. Thanks for listening.